Hello everyone and welcome to my channel. Okay, so we are going to discuss the congestive cardiac failure and endocarditis, infective endocarditis in this video, which are the last two topics of CVS. So the first topic that we will be discussing is congestive cardiac failure. So we are having a scenario that there is a 4 years old girl present with breathlessness. She was well until 7 days ago when she developed a nasty cold and fever. She has progressively deteriorated and her immunization is up to date. On examination, pulse is 130 per minute, respiratory rate 25, PP 80 by 60, and of A febrile, and on 25% centile for height and weight. She has slightly cold peripheries and capillary refill time of 2 seconds. She has loud gallop rhythm and palpable liver. Pulses are easily palpable in all the four limbs. Chest X-ray shows globular enlargement with pulmonary plethora. So, what is the diagnosis? It is the congestive cardiac failure. Another scenario is that there is a 1-year-old infant presents with palin and respiratory distress, respiratory rate 100 per minute, and heart rate is 180 beat per minute. She also has a gallop rhythm. X-ray chest shows cardiomegaly. Echo shows poor ventricular function, dilated ventricles, and dilated left atrium. So, what is the diagnosis, the investigations, and the causes, and then the management options? So we are having the diagnosis of congestive cardiac failure, and the investigations that are done are X-ray chest. That is, X-ray chest shows cardiac enlargement. Pulmonary vascularity is variable depending on the etiology of heart failure. Fluffy perihilar pulmonary markings suggestive of the venous congestion, and acute pulmonary edema are usually seen only with more severe degree of the heart failure. Now on ECG shows ventricular hypertrophy, left to right ventricular ischemic changes in cardiomyopathies. Low voltage QRS morphology with ST and T wave abnormalities suggests myocardial inflammatory disease or pericarditis. And ECG is not best method to evaluate rhythm disorder is a cause of heart failure. Arterial blood gases are done, which shows the arterial oxygen levels may be decreased when ventilation or perfusion inequalities occur secondary to pulmonary edema. When heart failure is severe, respiratory or metabolic acidosis may be present. On echocardiography, assessing the ventricular function, Doppler studies should calculate cardiac output. Now, the causes of congestive cardiac failure in infants are severe anemia, hemolysis, fetal maternal transfusion, and supraventricular tachycardia and complete heart block. In neonates, the causes are fluid overload, patent ductus arteriosus, ventricular septal defects, supraventricular tachycardia, metabolic causes that is hypoxia, hypoglycemia, acidosis, anemia, and sepsis, asphyxiated cardiomyopathy, viral myocarditis, and left-sided obstructed lesions. In children, the causes are rheumatic fever, acute hypertension, viral myocarditis, cardiomyopathy, cor pulmonale, and severe anemia. Now, the management options are general management and specific management. In general management, bed rest, position of the patient, that is semi-upright position at angle of 20 to 30 degree in bed to reduce the venous return pressure. In feeding, increase daily calorie intake, start restriction, then patient is admitted. Record vital stages, signs 1 only for first 24 hours. Maintain intake output record. Oxygen therapy give 4 to 6 liters per minute. Fluid restriction is then that is 75 ml per kg per day or 2 to 3 of the daily requirement. Then treat the infections with the antibiotics. Monitor and maintain normal values of the hemoglobin, calcium, potassium, and pH. The specific measures are blood transfusion, that is slow packed cell 10 ml per kg. Then diuretics are given, which are furosemide, that is 1 to 2 milligram per kg. Spironolactone is given 2 to 4 milligram per kg, and digoxin is given, which is the drug of choice. Inotropic drugs are given, which are dopamine and duvitamin, and used when BP is low, urine output is low. Oh, okay. When urine output is low. Okay. Inotropic drugs are given when urine output is low, and vasodilators are given which when reduced after load on the ventricles by peripheral. Alhamdulillah. Reduced after load on ventricles by peripheral systemic vasodilation, and captopril is given, nitroprusides are given. These are the specific measures, that is medical management, which are given in the case of congestive cardiac failure. So we have discussed the congestive cardiac failure, then we have discussed the scenario, that what are the diagnostic points. It is cardiomegaly and gallop rhythm. Then investigation options, which are X-ray chest, ECG, and arterial blood gases. Then we have discussed the causes, which are infants, in neonates, and in children. Then we have discussed the management options, which are general measures and specific measures. Now coming towards the next topic, that is infective endocarditis. we are having a scenario that there is a 7-year-old boy mm, admitted in bed with complaints of fever for last 3 weeks. He has been to multiple general physicians, but no improvement occurred. On examination, there is clubbing, splenomegaly, and splinter hemorrhages. On auscultation, there is changing murmur at left lower sternal border. So, what is the diagnosis, investigations, and the management? The diagnosis is infective endocarditis. The causes are Streptococcus viridans for 50%, Staphylococcus aureus and Staphylococcus epidermidis for 30%, Enterococcus and H. influenza, and Pseudomonas. Now, the investigations for diagnosis are Duke's criteria, that is 2 major or 1 major and 3 minor criteria or 5 minor criteria. The major criteria are positive blood culture, positive echocardiogram, and new valvular regurgitation. The minor criteria are prior infective endocarditis, drugs use, fever, major active emboli, septic pulmonary events, mycotic aneurysm, intracranial hemorrhage, conjunctival hemorrhage, JNV lesions, glomerulonephritis, ocular node rough spots, and positive rheumatoid factor, single positive blood culture, and active infection. Now, the investigation options are ESR, which is usually raised, and leukocyte count may be normal or raised, may be microscopic, hematuria present. On the blood culture, critical for diagnosis, at least 3 blood cultures should be obtained within the 24 hours, and echocardiography localized vegetation. The treatment options for infective endocarditis are organism specific antibiotics are given for 4 to 6 weeks, benzyl penicillin plus gentamicin for streptococcus, vancomycin plus gentamicin for staphylococcus, and amphotericin B for fungal. The surgery options are failing medical therapy. The surgical options are applied when the medical therapy fails, and it is done for large mobile vegetations, aortic valve disease with unstable hemodynamics, and severe worsening congestive heart failure with or without immobilization or persistent infection, and fungal endocarditis. Now, prophylaxis is done for antibiotics prior to invasive procedures. Amoxicillin and antibiotic prophylaxis are given, and cardiac transplantation is done, which is the recipient with cardiac valvopathy, that is prosthetic cardiac valve, past history of the infective endocarditis, unrepaired cyanotic heart disease, and repair of the congenital heart disease. So, we have discussed the infective endocarditis, its scenario, then the diagnosis, the causes, the criteria for it, which contain both major and minor criteria, that is the Duke's criteria, and the investigation options and the treatment, and then the surgery and the prophylaxis for the infective endocarditis. In the next video, we will start our most important chapter of the pediatrics, that is neonatology. Thanks for watching.